Okay. So good evening to one and all present here today. I am really glad to invite you for awareness session on sickle cell disease, or known as sickle cell anemia. We have Professor Dr. Bharat Parmar sir from Zydus Medical College Hospital, Dahod. He has been working in treating and doing research in SCD for quite some time now. And also he is known as an expert in treating sickle cell disease in India. He has been nominated for the various state governments, especially from Gujarat government, along with a lot of pharma companies, to understand the developments and research implications in sickle cell disease. Over to you, doctor.
Okay, thank you. Thank you for your kind words. May I start?
Yes, doctor. Yes.
Okay. Sickle cell anemia is the second commonest hemoglobinopathy in India, characterized by presence of an abnormal hemoglobin, that is hemoglobin S, due to substitution of glutamic acid by valine at the 6th position of beta chain. On a genetic base, in case of sickle cell anemia, there is a deletion of beta globin gene on a chromosome 11 is a basic genetic defect in sickle cell anemia, which may be two types: homozygous sickle cell disease and heterozygous sickle cell trait. In homozygous sickle cell disease, with a complete replacement of hemoglobin A by hemoglobin S, and in heterozygous sickle cell trait, there is a hemoglobin S concentration 35 to 45%. In addition, many cases have mixed hemoglobinopathy, that is hemoglobin S thalassemia and hemoglobin SC disease. Sickle cell disease is characterized by presence of sickle hemoglobin, chronic hemolysis, vaso-occlusive crisis with a recurrent pain episodes, multi-organ dysfunction, and early death. What is the etiopathogenesis of sickle cell disease? In a normal oxygenated state, hemoglobin S function normally. However, hypoxic state, deoxygenated hemoglobin S, it develops abnormal coupling of globin chain to deform the shape of RBC in a sickle form. While this sickling is reversible in initial stage, persistent hypoxia leads to irreversible sickling of RBC, which are then trapped in a microvasculature and spleen to produce vaso-occlusive lesion and hemolysis respectively. Slugging of deformed RBC in a small vessel further aggravate hypoxia and sickling. Thus, three factors are mainly responsible for pathogenesis of sickle cell anemia. One, vaso-occlusive events. Second, chronic hemolysis. And third, local as well as generalized hypoxia due to A and B, there is a vaso-occlusive events and chronic hemolysis. The pathology of sickle cell disease goes beyond the red blood cell. So traditionally, the sickle cell disease pathology was thought to be due to vascular blockage caused by sickle RBC. And there is a polymerization of hemoglobin in deoxygenated condition. So the current perspective of the blockage of this multifactorial nature of sickle cell pathology: one, there is a neutrophil activation and inflammation, then lead to enhanced adhesion, then lead to chronic hemolysis, polymerization, and endothelial activation. So the key drivers of vaso-occlusion is endothelial activation, enhanced adhesion, neutrophil activation, polymerization, and chronic hemolysis. So key driver I already told. So there is a vascular damage in sickle cell disease, which involve not only the RBC but also WBC, platelets, and endothelial cell. So polymerization of deoxygenated hemoglobin S is a primary event in a pathology of sickle cell anemia, and the pathogenesis of vaso-occlusion is a complex. Hemoglobin S is insoluble in low oxygen tension and polymerized as a long fiber, which result in the red cell becoming sickle shape. And vaso-occlusion is caused by the addition of the sickle erythrocytes and the leukocytes to endothelium, which result in a vascular obstruction and tissue ischemia. And the degree of sickle erythrocyte adhesion correlate with the vaso-occlusion and increased severity of the disease. And activated and adherent leukocytes are a likely driver of vaso-occlusion in collecting venues, whereas sickle erythrocyte may contribute to occlusion of small vessels. So complex effect of sickle cell disease go beyond the red blood cell, vaso-occlusion, hemolysis, and anemia, and chronic vascular damage and hemoglobin S polymerization, inflammation and cell activation, and sickle red blood cell sickling and hemolysis. So vaso-ocular crisis are a clinical hallmark of sickle cell disease. VOC may be only the tip of iceberg when it comes to the ongoing vaso-occlusion. So VOC clinically visible and can be unpredictable, extremely painful event that lasts on an average 10 days. Vaso-occlusion, multicellular adhesion, inflammation and cell activation, and subclinical ongoing and often silent VOC occurs systematically during the patient lifetime, potentially regulating in acute and chronic complication. In addition, platelet bind to the erythrocytes, monocytes, and the neutrophil to form aggregate which contribute to the abnormality of blood flow in a patient of the sickle cell disease. Although the addition of the leukocyte to endothelium during inflammation can involve multiple molecules, the process initially by p-selectin. So p-selectin is found a storage granule of resting endothelial cell and the platelet and rapidly transformed to the cell membrane on activation of cell during the process of inflammation. So p-selectin that is exposed on a surface of endothelium, it mediates abnormal rolling and static adhesion of sickle erythrocyte to vessel surface in vitro. So VOC, the p-selectin is responsible due to this p-selectin. So VOC are a number of one cause of hospitalization for sickle cell disease. So VOC events leads to hypoxia, ischemia, and tissue damage, and giving rise to the pain experienced by sickle cell disease. So VOC is a hallmark of sickle cell disease, and clinical features include the rapid onset of severe pain and one or more joint and extremity, and each VOC associated with inflammation that worsen with recurring episode and leading to serious complication and end organ damage. So VOC clinically visible are extremely painful event and that last on average 10 days. So, and vaso-occlusion, multicellular adhesion, inflammation and cell activation and endothelial damage, there is a subclinical and silent VOC ongoing occurs systematically during the patient lifetime, potentially resulting in acute and chronic complication. So first in VOC there is inflammation and cell activation. Second, vaso-occlusion and VOC. Third, organ damage. And VOC were defined a patient-reported emergency department visit and hospitalization for the pain treatment in. So vaso-occlusion it leads to end organ damage, multi-organ failure, and early death. So what is the effect of VOC on a different organ, there is an organ dysfunction. In brain, at least 25% of the patients with sickle cell disease experience a neurological complication in lifetime. In kidney, there is a 18% of all death in the patient with sickle cell disease have been associated with kidney dysfunction. In reproductive system, 35% of the men will experience priapism, and women are at an increased risk of VOC during menstruation. And in lung, there is a 75% experience acute chest syndrome, and 20% patients suffer from pulmonary hypertension in sickle cell disease due to VOC. And in liver, there is an organ damage to the hepatobiliary system, typically the result of vasoocclusion. There is a 40% of the liver dysfunction in case of VOC in sickle cell disease. So sickle cell disease is a multi-system disorders that affect the nearly every organ in the body, including heart, eyes, and the bones. So what is a treatment protocol in case of VOC due in sickle cell disease? First, there is a good hydration, especially during exercise. Second, adequate sleep. Third, temperature management, including avoidance of extreme cold, and also avoid emotional stress and use stress coping skills. What is the role of blood transfusion of sickle cell disease? So blood transfusion play an important role in the treatment and the prevention of acute and chronic complications of sickle cell disease. Transfusion can either be a single procedure or as a part of long-term treatment regimen. And short-term side effect, there is a volume overload and acute non-hemolytic reaction. And due to the long-term side effect of the blood transfusion, there is a alloimmunization, hyperhemolytic transfusion, and reaction and iron overload. So the aim of transfusion is increase the oxygen carrying capacity, restore blood volume, and prevent VOC and reduce sickle erythropoiesis. So what is the epidemiology of sickle cell anemia? The sickle cell anemia is the most common in African and American blocks, and in India, it is highly prevalent in Aboriginal tribe, there's a Teli, Mahar, Kumbi, etc. of the central India, in also Orissa, Chhattisgarh, Vidarbha, and in Gujarat, there's the Dahod and Godhra. So what is the clinical expression or manifestation of sickle cell disease? The clinical manifestation of sickle cell anemia depend whether the case is homozygous or heterozygous. The presence of high fetal hemoglobin, it prevents the manifestation of sickle cell disease during the first few months of life. The homozygous sickle cell disease usually manifests beyond 4 to 6 months of the age. Chronic hemolytic anemia with a moderate pallor and signs of chronic hypoxia and exertional dyspnea and growth failure sign of hemodynamic compensation. There is a CCF and cardiomegaly, while older children may also develop gallstone due to excess bilirubin production. Moderate splenomegaly with or without hypersplenism. Splenomegaly frequently regress after 5 to 6 years due to autosplenectomy after repeated splenic infarct. An altered splenic function predisposes this case of serious infection, that is sepsis, meningitis, and osteomyelitis by capsular organism, that is pneumococci, H. influenza, and salmonella. The signs of microvascular ischemia and recurrent infarct, there is a clubbing, nephropathy, chronic leg ulcer, and recurrent epistaxis. The sickle cell nephropathy characterized by recurrent hematuria and hypostenuria and the loss of concentration capacity due to recurrent medullary infarct. Hallmark of the sickle cell disease, there's a sickle cell crisis. There's a different variety of the crisis in case of sickle cell disease. Hemolytic crisis, hyperhemolytic crisis, vaso-occlusive crisis, aplastic crisis, sequestration crisis, and megaloblastic crisis. So acute crisis episode, which may be spontaneous or develop after exposure to the hypoxic event, that is fever, infection, dehydration, acidosis, and high altitude. These are the risk factor to developing the sickle cell crisis. The main type of crisis in sickle cell disease, there is a vaso-occlusive crisis, is the most common and usually spontaneous with a wide clinical spectrum. Sudden painful swelling of the hand and feet due to the ischemic necrosis of the small bone, it is called hand-foot syndrome. Acute abdominal pain due to mesenteric ischemia. Cerebrovascular stroke, acute chest syndrome, there is a pulmonary embolism, sudden blindness due to retinal occlusion, priapism due to the venous obstruction of corpora cavernosa. So vaso-occlusive crisis precipitated by cold, hypoxia, infection, dehydration. Sequestration crisis with a massive splenomegaly with a circulatory collapse due to sudden pooling of blood in a spleen and are most commonly in a younger child, usually after an acute febrile illness. It occurs in spleen, chest, and the liver. So hemolytic crisis is usually accompanies a painful crisis. Hyperhemolytic crisis with a sudden and severe hemolytic episode seen in a case with coexisting G6PD deficiency. So this hyperhemolytic crisis mostly occurs associated with G6PD deficiency. Aplastic crisis with a sudden bone marrow depletion and pancytopenia are usually associated with a parvovirus B19 infection. Megaloblastic crisis, there's a megaloblastic anemia following chronic hemolysis and chronic erythroid hyperplasia leading to the folate deficiency and sudden arrest of erythropoiesis. So hemoglobin can be dropped markedly as much as 2 to 3 gram percentage DL, and supplementation of the folic acid is a mainstay treatment in sickle cell disease. The painful abdominal crisis, vaso-occlusion of mesenteric artery lead to localized area of bowel dysfunction, and there is a severe abdominal pain and signs of peritoneal irritation. So persistent bowel sound, it differentiates it from the acute abdomen requiring surgical exploration. It usually resolved in the period of 3 days. The management of this painful abdominal crisis, there is a bowel rest, maintenance of hydration by IV fluid. Vaso-occlusive crisis, this occurs due to the obstruction of microcirculation. Obstruction of capillary of bone marrow causes ischemic necrosis and the death of bone marrow and initiate inflammatory response, increasing intramedullary pressure. Clinically, there is a swelling over affected bone with a severe pain and tenderness in younger children. Affect the small bone of the hand and feet, causing hand-foot syndrome or dactylitis, and child gets aches and pain due to this hand-foot syndrome and dactylitis. The management of this hydration and analgesics. Avascular necrosis of the bone occurs secondary to the vaso-occlusion of nutrient artery, femoral head, humerus, and upper end of tibia can be affected, but severe disability more common secondary to the femoral head necrosis due to the weight bearing. Neurological involvement include paresis, hemiplegia, and monoplegia, and common age 3 to 10 years. It results of occlusion of major blood vessel. About 70 to 90% of the children get repeated episodes. And the management is chronic transfusion regimen to keep the hemoglobin level less than 30%. Infection. These children are a higher risk of infection with encapsulated bacteria such as Streptococcus, pneumonia, H. influenza, and meningococcus. and Salmonella species. They are at risk of overwhelming infection, particularly if more than 3 years of age, with meningitis, septicemia, and pneumonia. So which are the long-term complications or the problem due to sickle cell disease? First, failure to thrive due to the chronic disease, pigment gallstone due to the hemolysis, Salmonella osteomyelitis, aseptic necrosis of the hip, priapism due to the pooling of the blood within corpora cavernosa, renal failure, congestive heart failure, proliferative retinopathy, splenomegaly in infancy with autosplenectomy due to splenic crisis, and later leg ulcer. So what is the clinical features of heterozygous sickle cell trait? It is usually asymptomatic and mild, though the mild vaso-occlusive manifestation may develop in a severe hypoxic condition. Identification of these cases by high risk and family screening is vital for genetic counseling. And mixed hemoglobinopathy usually have a milder presentation, except hemoglobin S, beta thalassemia, which clinically indistinguishable with sickle cell disease. So which investigations should be carried out in case of sickle cell disease? First, there is a peripheral smear showing characteristic sickle RBC with poikilocytosis, target cells, nucleated RBC, whole jolly body, signs of splenic dysfunction. Second, there is a sickling test, simple screening test to demonstrate sickling in suspected case. Hemoglobin solubility test involve adding measured amount of hemoglobin in a concentrated reducing solution. So turbid precipitate indicate presence of hemoglobin S. And hemoglobin electrophoresis is confirmatory, which reveals concentration of the various hemoglobin. So the sickle cell disease confirmed by hemoglobin electrophoresis. So in case of sickle cell disease, due to this hemoglobin electrophoresis, the result adult hemoglobin 0 and S hemoglobin 85 to 95%. While in case of sickle cell trait, adult hemoglobin 55 to 60% and hemoglobin S is 40 to 45%. Other investigation may reveal non-specific evidence of hemolytic disease. There is a moderate anemia, high reticulocyte count, hypercellular marrow with erythroid hyperplasia, and hyperbilirubinemia. Antenatal diagnosis is possible at 12 weeks by DNA PCR study in a fetal fibroblast. So what is the management of sickle cell disease or anemia? The prevention and early treatment of precipitating event, fever, infection, dehydration, acidosis, hypoxia due to any cause including high altitude. Supportive treatment in acute crisis with IV fluid and electrolyte alkali therapy to prevent acidosis and blood transfusion, and simple analgesic, that is paracetamol, and cold fermentation may be used to reduce pain in vaso-occlusive crisis. And treatment of chronic anemia. Repeated transfusion are generally not required except in severe case and during the crisis, and folic supplementation are necessary in all cases due to increased erythropoietic activity. Preventions of infection due to splenic dysfunction with pneumococcal, meningococcal, and H. influenza B vaccine, and children more than 2 years should receive penicillin prophylaxis from 3 to 4 months of age, as a current pneumococcal vaccine may be given only after 2 years. During surgery, transfusion are performed preoperatively for major surgery to reduce hemoglobin S fraction less than 30%. In sickle cell disease, Anesthetic care is taken to keep the patient warm and well oxygenated and hydrated, pain free, and acidosis avoided. The main treatment in sickle cell disease, there is a hydroxyurea therapy. Hydroxyurea is a myelosuppressive agent to stimulate hemoglobin F production. Somewhat, hydroxyurea also prevents hypoxia. And hydroxyurea reduces hospitalization due to vaso-occlusive crisis, need for blood transfusion by 50%. It is relatively safe and well tolerated in children about 2 years of age, except the potential but a reversible risk of bone marrow suppression. Typical starting dose of hydroxyurea is 15 to 20 milligram per kg per day, once a day, which may be increased 5 milligram per kg every 8 weeks to maximum dose 35 milligram per kg per day. This hydroxyurea therapy should be temporarily discontinued if absolute neutrophil count less than 2000 millimeter cube and platelet count fall below 80,000 millimeter cube. So many patients still experience recurrent VOC while receiving hydroxyurea. Many others are unwilling to use hydroxyurea. So what is the role of hydroxyurea in sickle cell disease? So what is the effect on blood markers? In blood marker, there is a hemoglobin, fetal hemoglobin percentage, mean corpuscular volume, and leukocyte count increase. And clinical markers, there is a pain crisis, hospitalization, blood transfusion, and acute chest syndrome decrease due to hydroxyurea therapy. Also, these preventions of end organ damage of the spleen, brain, and kidney still not evaluated during this trial of this hydroxyurea. And due to hydroxyurea therapy, mortality also decreased. So what is the short-term effect of this hydroxyurea therapy? There is a leukopenia, thrombocytopenia, and anemia. So what is the protocol treatment in vaso-occlusive crisis? First, there is a hospitalization. Do CBC, retic count, blood group, LFT, RFT, CRP, and blood culture. X-ray chest if respiratory symptoms, and ECG there is a pulmonary hypertension, and strong analgesia, there is IV opiates, IV fluid 50% above usual formula, oxygenation, CPAP if necessary in acute chest syndrome, and bed rest and keep the patient warm, and monitor closely saturation, pulse, blood pressure, respiratory rate, pain and nausea, and IV antibiotic if infection present or suspected. Transfusion if necessary, multiple may be needed. Exchange transfusion if indicated, this decrease the proportion of sickle cell. In severe painful crisis, also in neurological damage, sequestration, sickle chest syndrome, and priapism. So what is a newer modality in case of sickle cell disease? There is a bone marrow transplantation, other hemoglobin F stimulating agent, there is a bititrate and 5-azacitidine, and hemoglobin F reducing agent, DDAVP and calcium channel blocker, membrane stabilizing agent, that is a zinc therapy, hemoglobin solubility increasing agent, that is urea and cyanate, and newer modalities, there is a recombinant human erythropoietin, and also genetic counseling and carrier detection and antenatal diagnosis is essential in all cases to prevent further morbidity in the family due to the sickle cell disease. So the newer therapy, there is a crizanlizumab, is a specific therapy for sickle cell disease for VOC. Crizanlizumab is the first and only targeted monoclonal antibody that works by inhibiting beta P-selectin mediated multicellular adhesion in sickle cell disease. And the dose of prednisone, there is a 2.5 milligram per kg or a 5 milligram per kg loading dose 2 weeks apart, the first dose, and the maintenance dose every 4 weeks, and each dose administered intravenously over a period of 30 minutes. It is a humanized monoclonal antibody that binds to P-selectin and block its interaction with P-selectin glycoprotein ligand. So humanized monoclonal antibody, it binds the P-selectin and block its interaction with its ligand, including P-selectin and glycoprotein ligand. So prednisone, when you give 2.5 milligram per kg, there is a 32% reduction in VOC, leading to the healthcare visits. Not satisfactorily significant, but when you give 5 milligram per kg, statistically significant and clinically meaningful reduction of VOC, leading to the healthcare visit, and confirmed by supplementary analysis, varying with population and management dropouts. So due to this prednisone, 45% reduction in a number of VOC per year, and more than 1/3 patient had a no VOC in 1 year, and 40% reduction in a days hospitalized per year, and delayed time to first VOC longer. So majority of the adverse drug reaction due to this therapy is mild and moderate, no increased risk in infection, blood count result and blood chemistry finding similar to those placebo. So concluding remarks of the sickle cell disease, there is a VOC may be only the tip of iceberg when it comes to the ongoing vaso-occlusion, and multicellular adhesion, it promotes vaso-occlusion, and VOC is a vicious cycle in a sickle cell disease. And vaso-occlusion and VOC can lead to end organ damage, multi-organ failure, and death. And VOC has been associated with increased risk of death at an earlier age. And VOC can be managed by using hydration, supplemental oxygen, appropriate analgesics, and sickle cell disease patient may avoid seeking healthcare assistance during a VOC because of stigma around opioid use, poor provider knowledge, and structure of their healthcare system and expense. So there are forms of management of therapy and preventive treatment, including blood transfusion, hydroxyurea, but there is an unmet need for additional preventive therapy. Thank you.
Thank you, Doctor. Before going to the Q&A, I have a small yeah. So before going to Q&A, I have a small poll for the participants who have joined now. So I'm just going to share the poll right away so that the viewers can answer. Like, it's a few questions about sickle cell disease, maybe what they have understood till now, so that from there we can take the Q&A. So I'm going to launch now. Yes, so I've just started the poll. So the first question is, people with sickle cell disease cannot get malaria. So that is the first question. Is it true or false? The second question would be, sickle cell disease affects different people in different ways, but almost always includes pain. That is the second question. Third question would be, a woman with sickle cell disease cannot have a healthy pregnancy. Is it true or false? So these are the questions that I have asked. And doctor, over to you. Maybe there are a couple of myths and facts that, connected with sickle cell disease. People says that women might have a difficult pregnancy, during this time. So what is your opinion about it?
So in case of pregnancy, is a precipitating factor for this development of hypoxia, but not difficult one. So there is a not that much affected in pregnancy.
Okay, doctor. And the another thing would be, you mentioned about the pain factors during
Right.
the SED. So what are the basic treatments that you have done and you are still doing to manage those kind of pain?
So for in the case of VOC, there is a painful crisis is there. Use these analgesics. There is a paracetamol 10 to 15 milligram per kg body weight. And in case of there is a severe condition is there, then also use IV opiates in case of pain due to this crisis.
Okay, doctor, thank you. And most of your work is in and around the rural population.
Right.
So how do you start giving the awareness in the rural population and treating them? Because I understand that the cost of treatment for SED is quite high, huge. How do you manage and to treat those patients, maybe in creating awareness and everything? Yeah.
By taking a detailed history about this sickle cell disease, how many family members are affected, and also we are doing the sickle test. If it is sickle test is positive, then confirmed by the hemoglobin electrophoresis. And also we advise certain precipitating factor. There is a chances of precipitating crisis like hypoxia, acidosis, dehydration, extreme cold, extreme heat, and infection. So also we are giving a folic acid as a supportive therapy to prevent megaloblastic crisis, and also this prevent crisis. The rehydration, we advise about the correct this dehydration when there is a crisis there. Give also analgesic, etc.
Okay, thank you, doctor. And coming to the question with reference to malaria, because there were a couple of people who have asked me, is there some link between treating in malaria?
So in case of sickle cell disease and also in thalassemia, they are resistant to malaria. Literature says, but there's a specific cause why there is a resistance due to the in sickle cell disease and thalassemia, there is a no malaria.
Thank you, doctor. Also, would you like to highlight one or two cases that you have dealt in treating the patients? Maybe one or two that would enhance the audience who are listening right now.
What do you say?
One or two cases that you have dealt so far. Maybe it was very crucial for you while treating the patient. Maybe one, if you can share your experience, what you have done.
Right. Okay. When any child came to me, when he presented with 3P, there is a pallor, pain, and pyrexia until there is a sickle cell crisis. When there's this sickle cell crisis patient admitted in hospital, so find out what is the cause of this crisis, whether it is due to the diarrhea and dehydration or whether due to the pneumonia or hypoxia. So if it is due to the diarrhea and dehydration, we should give this IV fluid and IV fluid therapy to correct dehydration and manage the crisis. If the child presented with pneumonia and hypoxia, to give oxygen and also antibiotic, and this prevent this crisis complication.
Okay, doctor. And one more question. Just wanted to understand the genetics part. Is it hereditary or like
So in case of sickle cell disease, there is a deletion at the 6 positions. There is a beta chain. There is a sickle cell disease genetic basis. That the 2 types. One is homozygous sickle cell disease and second is heterozygous sickle cell trait. In sickle cell disease, there is a homozygous. There is a complete absence of this beta chain. While in case of the sickle cell trait, there is hemoglobin S. It is percentage is 35 to 45%. Complete absence of hemoglobin S in sickle cell anemia and 30 to 45% absent presence of hemoglobin S in sickle cell trait.
Thank you, doctor. And maybe this is in terms of the life expectancy of a person who is infected with sickle cell anemia. What is your thought on this? What will be the what are the treatments available now? Is it like really threatening that maybe the patient have to count their days accordingly? Like, what is your thought on this?
Right. If in case of sickle cell anemia, when there's a confirmed diagnosis of sickle cell anemia is there, so we are first to prevent this factor and prevent the crisis. So there is a regular follow-up is important. Second, advice about the immunization. Third, advice about the nutrition, also the folic acid. So these are preventive aspect. But when there is a patient admitted in the hospital, according to the cause, treatment given to the patient and prevent this organ dysfunction and give this specific treatment for this sickle cell disease is a hydroxyurea. So the dose is also important for the hydroxyurea initially to start 15 to 20 milligram per kg body weight, and every 8 weeks the increase 5 milligram per kg, 8 milligram per kg, and maximum dose is 35 milligram per kg per day. So hydroxy is the main therapy in case of sickle cell disease. If there is any blood marker, there is in alteration is there, anemia, leukopenia. So when there is a blood WBC count, leukocyte count less than 2000 and platelet count less than 80,000, this stop temporarily this hydroxyl therapy. So specific therapy for sickle cell disease, hydroxyurea, preventing all factors, and also the folic acid therapy. So if this regular follow, then there increase the life expectancy of the children or the adult.
Okay, doctor. I think we have taken up all the questions. Now I'll share the results, like the poll that we have conducted, so the viewers can see the results for the questions that we have asked and your thoughts about it. So, doctor, thank you so much for spending your time today in detailing all the various aspects of sickle cell disease, the treatments, the prevention methods, nutrition that involved, and what all treatments that the person can avail now in treating the sickle cell disease. Thank you so much, doctor, and thank you so much, attendees, for joining us on a Friday evening. Thank you so much.
Thank